this stage. Good afternoon, Facebook and our members. It's good to see everyone. Let's make sure everything's going good there. I'm a little thirsty, so let's have a little drink here. Okay. Well, welcome to another case study breakdown. I'm excited to have you all here and talking about hyperkalemia. Now, we had a video go out yesterday about hyperkalemia and how to manage this patient. And you know what? Today we are going to go more in depth because we did a case today as well. Hey, Alaska, how's it going? Is it Shannon? Yeah. So we're going to be kind of taking a deep dive into this. There is going to be some technical stuff to talk about, but I'm going to draw everything out today. That's my plan, is to draw as much as I can so that way you can follow how electrolytes are working in this case, because that's really what hyperkalemia is all about. Is the essentially the amount of shift of potassium throughout the cells. That's kind of what we're dealing with right now with this particular patient. And so I want to help you understand how this all happens. And the best way I can do that is to actually draw it. So we're going to get technical today, but I'm hopefully going to put it in a position where you guys can all follow it. So that is what we're talking about. All right. If you guys haven't heard yet, we are hosting our very own in-person conference, not a virtual conference, an in-person conference where you can meet all of us, all the people at Master Medics. You can meet all the people at Flightbridge Ed. We are doing this big conference in Calgary, Alberta. It's a big city in Canada. If you guys haven't been there, it's fantastic. There's a lot of direct flights that go there because it's a big hub in Western Canada. But we're going to be hosting a big conference there where it's going to be a kind of like TED Talk styles, where it's going to be 20-minute sessions of speakers from all over the world that are going to talk about some of their interesting experiences, their cutting edge things that they're doing. It's a conference that I go to in the United States every single year, and I speak at every single year. And we have partnered with Flightbridge Ed in order to bring it to Canada for the first time, partnered between Master Medics and Flightbridge Ed. So we're very excited to offer that to you, and you guys can hold your ticket. Pre-registration is open, so you can hold your ticket for $5. And then when we open up early bird registration on November 1st, you get direct access to those tickets at a cheaper price. And so if you want to do that, take a screenshot of that QR code and you can hold your ticket for $5. And you can hold as many tickets as you like. We're about half sold already. And so if you're thinking about it, this is a good way to hold on to your ticket so you don't lose out, because if we sell out, we sell out. We can't have more than 500 people into that room. That's where we're selling out, and we're half sold out already. So go ahead and jump on that whenever you're ready if you're interested. So that being said, let's get into this case. Okay, you are dispatched to a 56-year-old female patient experiencing generalized weakness and palpitations. The patient has a known history of chronic kidney disease and hypertension. On arrival, the patient is lying on the couch, visibly anxious and weak. Patient states that she has felt sudden onset of weakness earlier today, is now feeling too tired to move. She denies chest pain or shortness of breath. You begin with a standard assessment and treatment, and you place the patient on a low flow oxygen while you do your assessment and take a 12-lead ECG. Then this is what you see, and I'll show you that in just a second. You package the patient and start transporting to the hospital, which is 30 minutes away. So you got a 30-minute transport time, and the patient starts to deteriorate. And I'll show you the vitals here shortly. Skin is pale, cool, diaphoretic currently. Level consciousness is fatigued, but they're conscious and they're answering questions very, very slowly. Temperature is normal, eyes are pearl, and so they're reactive. And this is what your patient looks like on the couch. Really tired, really fatigued is essentially what you got here on this particular patient. So we got a female patient that is diaphoretic and very, very weak. Okay, so let's take a look at the vital signs. Okay, what do you see on these vital signs? Is there anything here on these vital signs? Heart rate 129, blood pressure is 92 on 59. ETCO2 is 34, rest rate currently is kind of between 15 and 20. SpO2 is 94%. Is there anything here that jumps out at you and you go, okay, what's concerning here? What's the problem, or anything that that you see that you're kind of like, okay, this is not good? What do you think? What vitals concern you? Is anything jumping out at you right now? What concerns you? Let's see what's going to fit. Shock index is fairly high. Yes, I agree with you. So shock index is your heart rate divided by your systolic blood pressure. If it's over 0.9, then you have a problem. And then in this particular case is like 1.2, 1.1. So it is high. Heart rate and BP, tachy, heart rate, blood pressure. Absolutely. Okay, so some things that, you know, if you look at one of the vital signs, let's go back here. I want to talk about the vital signs really quick here. If you just look at one of the vital signs, overall, this patient doesn't look horrible, right? I think we can all agree to that. But when you start combining things and looking at the whole picture, then you start to see a patient that is fairly ill. And that's why I always say, when you're looking at one thing, like the blood pressure, you should be looking at it in the entirety of the context. You have a heart rate of 129, 130. And that 130 is only maintaining a systolic pressure of 92. That is an important detail. So you need to be looking at the whole picture. If you just look at one thing, be like, oh, they're not hypotensive yet because they're above 90. But if you look at the big picture, this is a pretty sick patient that's going to deteriorate very quickly if we don't act. So that's something that I always try and teach you all, is that if you're looking at vital signs, don't just look at one number and be like, we're good. You got to look at the whole picture, look at the whole context, or you're going to miss things like this, where this patient is a lot more sick than the numbers, singularly the number, makes them out to be. Okay, so they're barely compensating here. I would consider this barely compensating. Okay, let's move on. So we take an ECG, 12-lead ECG, and this is what we get. Now you might have to squint a little bit to get a good look at it, but what do you see right off the hop that is telling you that this patient may have an electrolyte problem, particularly a potassium problem? Go ahead, throw that in the comments. What do you see? What do you see? Peak T waves. Okay, absolutely. S&T elevation. I don't particularly see S&T elevation. Where are you seeing it? That's not 1 mil. That's not 1 mil. That's not 1 mil. No. Maybe you could convince me that that's over 1 mil, but it's barely 1 mil. I don't see any S&T elevation that immediately kind of jumps out at me, but it's definitely something that can be a problem. But there's some other things that are concerning. It might be hard to see from video if you're looking right up to it. There it is. Brian's got it. I have a concern with how wide this QRS is. So the wide QRS should be 0.12, okay, which is 3 small boxes. This particular one, I'll just put it in red so you can kind of see what I'm doing here. This particular one is 1 box, 2 box, 2.5 to 3 boxes. So we're getting wider. We're not brutal yet, okay? But absolutely, these peak T waves are a concern. Okay, so we have a few things that are pretty bad. So absolutely, there's some signs that this patient has maybe a potassium issue, or in other words, a hyperkalemic state or a high potassium state. Now, just keep in mind that these peak T waves, they only happen in about 30% of hyperkalemic patients. And they also only happen in slightly elevated potassiums. Okay, you obviously won't be able to check an actual potassium in a lot of cases, but or hyperacute T waves or peak T waves don't happen and just stay happening. They start to flatten out. In fact, everything starts to flatten out. And that's what we're going to see with these T waves as the potassium gets higher and higher and higher. We're going to see it flatten out. We're going to see the QRS get wider. We're going to see the PRI and the P wave flatten out, because that's how these potassium or hyperkalemia patients start to develop. And so, yes, you caught them when they have hyperacute T waves, but they will go away as they get worse. So just keep that in mind. Do they have a medical history of kidney disease or dialysis? They had a medical history of kidney disease. Good catch. So yes, they did. Okay, so we have a patient that has a history of kidney disease. They are feeling weak, tired, unable to move. They have vital signs that are concerning, barely compensating, and then they have signs of hyperacute T waves with a developing or a widening QRS. Is there enough information here to suggest that we should be treating for hyperkalemia? Do you have enough? Go ahead and put that in the comments. Or are you going to continue to monitor and see what we should do from later on as this continues to develop? Or do you think that that's enough evidence to suggest that we should start treating it? I'm with you, Josh, in Paramed21 on TikTok. This patient has, it's 2.5 boxes, so it's not quite what you would consider wide QRSs yet, but we're getting there. It's developing, so it's not quite there. But we do have the hyperacute T waves. So yeah, I think that there's enough evidence for starting treatment on this patient, yeah? I'm with you there. Okay, so I think that we have enough evidence to suggest this is a hyperkalemic patient that needs to be treated. And just to review the physiology of what's going on here is that this patient has a problem clearing potassium. And by clearing potassium, I mean that the kidneys are unable to actually flush the potassium, because that's essentially what we need to do in order to maintain balance. Now, potassium should stay over here. Okay, in the intracellular states. And if we're not able to clear it, if we're not able for the kidneys to actually clear our potassium, then we start to develop a significant amount of potassium here in the extracellular area, and that includes the blood. So when we take a blood sample and we are looking for serum potassium, we're looking for potassium that's in the blood, and that's a direct representation of how much concentration that we have in the extracellular spaces, which includes the vascular space. So really, we want our high concentrations of potassium to be over here in the intracellular area, but we don't have that. We have a more concentrated area in the extracellular area. And this is a problem, especially when it comes to action potential. So when it comes to action potential, and this is kind of the graph form of it, is that we have our resting potential, okay? Our resting, oops, I'm still in the eraser. Resting membrane potential, and that's this right here. So minus 70 to minus 90. When you have an accumulation of potassium in that extracellular space, the place where it's not supposed to be, this resting membrane potential gets closer to this threshold. And this threshold is when we have action potential. So when we see the P wave and the QRS, we're seeing an electrical impulse that is high enough that's creating the contraction. That's the action potential. And so what we're seeing here is that this resting membrane potential gets too close to the threshold, and it creates a really irritated and excitable environment. And what happens when we get an irritable, excitable environment is that these sodium channels they start to close because they get basically overstimulated and they get irritated. So we're not having nearly as good shift of sodium and potassium. And by that means is that we're going to have a much slower depolarization. So to get that into context, just so that you understand, is that when you have a shutting down of those sodium channels because everything's too irritated and excited, it's kind of like having a little brother poking you, and eventually you just start ignoring them. That's what the sodium channels are doing, is that they are now in their ignoring state because they're too irritated. And what that means is that typically we want a really strong, fast contraction of the ventricles and the atriums. That's what creates the propulsion of blood. But when you have sodium channels that are irritated and are shutting down, it doesn't allow for the rapid shift of potassium and sodium, because those sodium channels, which are part of this depolarization phase, they're slow. And so we're left with some channels that are still operating, but we're operating in a much slower, kind of easy, willy-nilly type of environment, as opposed to the contraction that we really want. That's like having my water bottle here. Okay, this water bottle here, usually we want good, strong contraction, right? That propels blood. When we have decreased excitability of those sodium channels, we're left with really, really weak contraction. So we're not propelling blood nearly as well. That's why we see the QRS start to get really wide, because we need that strong contraction to create strong QRSs, so it gets wider. We start to see that the P wave starts to get wider because we're, again, left with sodium channels that just don't want to work because they're annoyed and frustrated and irritated. And so we're left with slow, weak propulsion. Okay, that is essentially what's happening in this state. So what are we trying to do? So what's the treatment to help this particular patient? Well, the goal is to try and restore some of that contraction. And the way that we need to restore some of that contraction is to basically apologize to the sodium channels, make them less irritated and annoyed. Okay, so basically what we're going to do is we're going to start off with our first drug, which is going to protect the heart, and that is calcium gluconate or calcium chloride. But the calcium ion is what we really need. And what that calcium is going to do is, remember, we had this kind of threshold that's kind of starting to thin out or get closer to the resting membrane potential. What calcium does is that it pushes that resting membrane potential closer to our normal. And this decreases the irritability of those sodium channels. So this is our apology, to make sure that the sodium channels start working again because they're less irritated. So that's what calcium is doing. And this is going to start to help the heart from progressing to further states and worsening states where, contraction is getting weaker and weaker. So essentially, this is buying this patient time. After we give calcium and buy our patient time and apologize to those sodium channels, then we can start looking at the other problem, which is the originating problem, which is too much potassium over here. Okay, we have too much potassium on the outside because this is the reason that we have such bad irritability. So we're going to use a few medications in order to promote the shift of this potassium and essentially hiding it in the cell. Okay, we're not getting rid of it. We're not making the kidneys get rid of it. We're not destroying potassium. All we're doing is we're temporarily moving potassium from here to here, so that way we can get this patient to the hospital and ultimately on dialysis. And so medications that can do that, first off, is nebulized albuterol. Nebulized albuterol promotes potassium to move from here to here. So we're hiding that potassium inside the cell by using nebulized albuterol. That's your first option in order to help treatment, a medication that is on most ambulances. Second one is bicarbonate. Now, bicarbonate gets a lot of flack because I think it was overused and we used to throw bicarbonate at everybody. We don't do that anymore because it has minimal effect. In this situation, there's a reason that it can be a benefit. And the reason being is that essentially what we're doing is that we're taking the pH of the body and we're essentially increasing it, making it more alkalotic by introducing more bicarb. Now, what does that do? Well, it actually, indirectly, is going to take the hydrogen that's in the cell, and when we have a more alkalytic environment out here, hydrogen from inside the cell wants to come out here and buffer it. When we have the promotion of hydrogen shifting to the extracellular areas, we get a shift of potassium into the cell. So by stimulating or manipulating the pH higher in an alkalotic environment, it promotes the hydrogen that's inside the cells to come out here and buffer it and try and normalize that pH. And by trying to open up these cells or these gates, potassium shifts in. So again, bicarb indirectly helps hide potassium from the extracellular to the intracellular areas. Again, only hiding it. So that's another medication that's used to, again, do the same thing that albuterol did, but in a more indirect way. Finally, the third one that's becoming more and more popular is insulin. Now, insulin, again, is going to promote the shift of potassium in the extracellular areas into the intracellular areas. So the third medication that's doing the exact same thing is hiding the football. Okay, hiding the potassium inside the cell. So that way we can reduce the excitability and the irritability of those sodium channels. But if you're giving insulin, remember that insulin is still going to want to promote glucose from here and promote it to shift into the intracellular areas. Okay, so we can cause hypoglycemia by just using insulin. So typically if we're using insulin in order to promote potassium shift, we need to make sure that we're combining it with sugar so that way we don't cause hypoglycemia, another problem when we're already dealing with a hyperkalemic state. Okay, so those are your three main options or four main options that we have in order to treat this patient. Again, the goal, first off, is to apologize to the sodium channels, and we do that by introducing calcium and separating the threshold of action potential from the resting membrane potential. Because remember, we're here right now when we have too much potassium on the extracellular area, and that calcium is going to restore that membrane. Okay, and that is the apology we give the sodium channels from being too irritated. That's the first thing. The second thing is that we're going to start to hide the potassium. The first medication that typically we use is nebulized albuterol. And that's going to help hide potassium inside the cell, so that way we have a restoration of the membrane. The second medication that we can use is bicarbonate. By increasing alkalosis, we promote hydrogen from inside the cell to come out. And by having the hydrogen come out, it promotes potassium to go in. So again, hiding the potassium inside the cell by manipulating pH. The third thing that we can use is insulin in order to, again, hide the potassium inside the cell. But if you're using insulin, don't forget to use glucose because you don't want hypoglycemia at the same time that you have a hyperkalemic patient. And so the whole point of all of this is not to fix your patient. Your whole point of this is to literally buy your patient time. Because what they need is dialysis. because there's no way to actually get rid of that potassium without either restoring kidney function or dialysis. Those are really the two options that we have here. And we can't do either of those things in an ambulance. And so what you're doing is buy this patient time before you get to the hospital, so that way they can get on dialysis or kidney restoration. Okay, because all you're doing is hiding potassium. Eventually, this potassium that's in the intercellular or inside the cells is eventually going to shift back. So that's it. That's all I got for you today of what we need to do with our hyperkalemic patients. Is first identify, and the best thing that we can do for these patients is start treatment early. Once we have enough evidence to suggest this patient is hyperkalemic, we should be starting treatment. Because once they get so high to the point that the potassium is so high, it may be too late and our treatments may be completely useless. So as soon as you identify it, start treating it. The second thing is that we're going to help restore that membrane with the calcium, and then we're going to hide the potassium inside the cell until we get to the hospital to buy this patient time. Any questions? Go ahead and put them in the comments. No, in this particular case, Brian, dialysis was not missed, but they did have a pre-existing kidney disease. So they may be a candidate for dialysis, but they hadn't gone it yet. I was talking about hyperkalemia, Syed. Does insulin drive sodium or potassium inside the cell? It drives potassium inside the cell. Yes, salbutamol can help as well, which is basically a similar medication to albuterol. You're correct. How would you ID hyperkalemia in an AMBO? So, Craig, when it comes to identifying hyperkalemia in an ambulance, there's a few things. First off, a pre-existing kidney disease, missed dialysis, something along those lines can be very ominous to a hyperkalemic patient. Okay, those are the main reasons that you're going to see hyperkalemia is patients that have pre-existing kidney disease, or renal failure, or patients that require dialysis and they missed it. Okay, that's the first thing. So what things you're going to find in your history. The second thing that you're going to look for are mostly ECG findings. Widening PRIs, widening QRSs, hyperacute T waves. Those are all things that suggest, in combination with the history, that this patient has a potential hyperkalemic state. So those are the big things. The third thing would be obviously a blood test to confirm. But we can't do that on an ambulance, so we're going to be using all the little clues in order to come to our suggestion that this patient has hyperkalemia. It's a tough one. But if you don't pull the trigger on treatment, then you can have a situation where this patient can go into cardiac arrest like that. We're talking 7 minutes. So a 30-minute transport in a patient that has a potassium of 6, it can go to 9 very, very quickly. And this patient will be likely or potentially in a PEA. So we got to take those little clues and really kind of drive them home, get on with our medical director or our transport physicians and have a conversation with them like this. And listen, this is what I think is going on. What are your thoughts? I want to treat with this. And have those conversations. Can I mention the doses? I try very much not to mention the doses. And the reason be that is because the doses vary between areas. And so I try very careful not to talk about dosing in these types of situations because there will be like some repeat dosing. And it depends on what type of calcium you're using. Is it gluconate? Is it chloride? Because that matters. And then also you're looking at bicarb, you're usually at like 1 milliequivalent, but again, it can go from 0.75 to 1.5. There's a lot. So I try really hard not to mention dosing in my talks. I know it can be frustrating, but the idea is to make this as inclusive as possible when we have such a wide audience. So that's why I try to avoid it. Sorry. When I start this patient on lactated ringers or normal saline, yeah, maybe. I've got other problems, right? So would I give them saline? I probably would start them at least on like, I'd maybe give them a 250 ml bolus or something like that. But my issue isn't a preload problem. It's not a end systolic volume problem that fluids are going to help. This is a action potential problem, right? This is a cardiac output problem that I don't think that fluids are really going to fix, but maybe I would support that blood pressure a little bit with some fluids, but I would be more targeting on how I can help the cardiac output, which is the treatments we've talked about. Good question. If the patient has severe shortness of breath, would you give the patient a pressor in order to maintain systolic? Potentially, would I give this patient a pressor? Same thing is that the treatments that I'm going to give, particularly the calcium, are going to help your cardiac output. So if I'm really thinking this is a hyperkalemic patient, I'm probably going to stick down that route and do the calcium. If my calcium does not help restore some of that blood pressure, then I'd be looking at potentially adding a pressor, but I'm going to be using that because really calcium is indirectly an inotrope that could help with cardiac output. And in a lot of cases, especially if you use it early enough, can help restore some of the issues that you're seeing here. In this particular case, that's the route I would go without adding a pressor unless I absolutely had to, and just relying on my calcium's inotropin effect. Do I see anything else? Collexolate, I haven't used it personally, so I can't really comment on it. Okay, so that's what I've got for you today. Again, don't forget, if you like the way that we teach, if you like how visual we are and you are a student, we do have a student portal for you that you can learn from us. So if you don't like learning from the textbook, if you don't like boring lectures, then this is something to take a look at, especially if you're struggling to understand medicine in school. If you like the way that I taught here, if light bulbs are going off, I strongly suggest checking us out at Master Your Medics and starting a 3-day trial, checking out our videos, checking out our content, and seeing if it works for you. Because if it does, you can stay as long as you like all through school, all through your exams, and let us help you get through it and understand medicine in a way that that you may not have been able to do through school by yourself, through your textbooks and through your lectures. We would love to support you in that. So don't forget to check us out and use us if you need to get through school. Don't forget that we are hosting a paramedic-based conference in Canada called FastCan. We are partnered with Flightbridge Ed and my company, Master Your Medics. You can hold your ticket before pre-sale or before the early bird sales open using this QR code. It is $5 to hold your ticket before the open registration November 1st, and we've sold about half the tickets already. And so if you are interested in FastCan and coming to see us on September 3rd and 4th, 2025. We would love to see you there. Hold your ticket for $5 so that way you don't lose your spot. Because when we sell out, unfortunately, and we're about half sold out, and we've only opened it up for a week. So we'd love to see you all there, and we'd hate for you guys to miss out if you didn't get a hold on your ticket. So thanks again for joining us today. We loved having you all here, and we will see you next time. Bye for now.